So what I'd like to go through to today is our daily assessment. So how do we actually test these players? And a little bit more about our treatment protocol, which I was quite happy when Bruce said that we have to be more lenient with our strategies, how we rehabilitate these players. Because at the moment, all that's out there is not criteria-based protocols. That's sort of like time frame based, and people just say, okay, I think you can go back, but there's no clear green line that follows the protocol. So we've decided on 3 stages with set criteria to progression, and like I said, being involved in professional sports, I think is really important to give a clear message to the coaches and to the players themselves. They want to know, where am I in my rehabilitation process? The way we did this was with daily reassessment. So we took some strength measures, as Nickel showed before, which I will elaborate a little bit later on and show you exactly how we did that. And in the end, we have the luxury of having 2 sports rehabilitators within Aspetar. So they performed a 3-day on-field sport-specific rehabilitation process where they push the player throughout their, or depending on what sports they're doing, trying to mimic their sporting activities on the field, followed by the end 45-minute session that should be close to a game situation. So I'm not going to go too much into the exercises themselves because it was a fairly open protocol, and probably what we did is what everybody would do with a grade 1 hamstring injury. So we started with some stage 1 isometric exercises, some gentle mobilization, some soft tissue treatment, some stationary bike. And if the players would come in really, really early, then a RICE regime would be applied in order to minimize bleeding and so on. So the progression criteria that we chose was that the athlete had to be capable of performing a stationary bike 2 times his body weight in watts power output. Why did we decide that? We thought that is about equivalent to start running. So the load should be very close to an easy jog. The other thing was, we said they had to be able to have a pain-free single leg squat, which again, push-off phase during running, we thought that would correlate quite well with starting to the next level. In stage 2, we took the exercises out of stage 1 again, increased speed, gave some more load, a bit more functional, so that means like squatting exercises, increase accordingly the weight. And then we started a running progression. So in order to, I want to show you a little bit the running progression, how we did that. So we started off with a walk. This is our functional area, as you can see here on top. That's an Aspetar. It's about 23 meters from one side to the other. We placed cones on each side, and we measured the speed of the player on the straight line, and then asked the player to self-rate his running speed. So if somebody starts off running, he says, okay, I did about 6 seconds from start to finish. They said, okay, how fast did you think you ran? About 30%. We can monitor that throughout the rehabilitation process and then see, is there a big variance between actually them thinking they're running much faster and the timing. Then we start with a jog, run, triple extension, where I play a quick video now, if it works. So this is Nickel performing some of the exercises. And as you can see, so this is the cones in the beginning. This is the triple extension with a high knee walk. So we did 3 laps of those in between the running progression. So they would do 3 sets of 4 laps running, and in between they do a sort of an active stretch, obviously pain-free. There should be no pain whilst they're doing these exercises. And then he gets a bit of a rest. So this should be a jump, but Nickel being South African, and he doesn't look much like a springbok there, this should be actually much higher. So it should mimic sort of the push-off phase when you're jumping. Same principle here, 1 lap. In the corners, again, he gets a little break to recover. And we start with the running progression. So we measure from point A to point B. We'll stand there with a stopwatch, and then let the player rate his perceptive running speed. as he progresses, obviously, we go faster and faster. So here Nickel is performing a little bit more of a sprint, and we keep that in mind. So again, the progression from the stage 2 to stage 3 then was he had to be able to run at 70% of his self-rated running speed, and he should be able to have a straight leg raise or a hamstrings feta, 75% to the other side, and it should be pain-free. Then in stage 3, we started with some lengthening exercises, and I'm saying lengthening exercises because we, in the beginning, thought this is eccentric strengthening, which it doesn't really look like it. We put an EMG on and saw very little muscle activity in the biceps and in the semimembranosus and tendinosus whilst doing these exercises. So there's a bit of a debate, what do we actually do here? Is it a lengthening exercises, motor control, or is it strength? We don't really know, and this has been shown by Askling to have very good results, obviously, in his studies. Then we've got a T-test, which is a 10-meter sprint looking like a T. Sorry, I have to go back on the slide here and show you this. So if you can see that here is the starting point. The player sprints, changes direction, comes back to the starting point, and we would really look at about 9 to 11 seconds to complete the sprint. Now, this brings us back to what Nickel was saying before. What is really important? What do we measure? And these are the things, again, that we found to be relevant and where we can make clinical decisions on how to progress our patients. So pain, functional tests, which I will demonstrate shortly, some flexibility tests, strength measures in mid and outer range, the gait, so gait meaning does he have pain when he's walking, jogging, and the palpation of pain and in its length. These are the tools that we've used. So we've got a handheld dynamometer, we've got a tape measure, we've got a goniometer that you can pick up in any hardware store for 2 reals, $5, 50 yen, I don't know, wherever you're from, but fairly easy to use. And we've got a Mulliken belt for fixation. So I would like to go now through the practical part of the session, and please stop at any time if you can't see or if you want any test repeated. So if Nickel could come up here. And as we mentioned, so the first thing that we do is we obviously ask the player, how do you feel? What is your daily average pain in your ADLs, in the activities of daily life? So when Nickel comes into me, I will ask him, so Nickel, how do you feel today? Right. And in his case, he's feeling great, so he has no pain. Then I will ask him to do bend forward with his knees and heels together and slide slowly down with his fingertips to the ground, and we evaluate pain. It is not of essence to see how far he can reach. He can be stiff. We don't actually care about that. It's just pain or no pain. The other thing we have to be aware of, if the patient is throughout his rehabilitation process loading the hamstrings more and more, obviously there could be soreness, and it could be confused between muscle soreness and the actual injury. Then the next test that we do is a double squat. So we decided, put it from the side, to have the bed at approximately the height of the posterior aspect of the popliteal fossa. So this is a bit more to standardize the test. And why did we choose that? We don't see weightlifters, so we don't have anybody that is really doing deep squats. We thought in our athletic population, that's more than enough. So we asked the patient to perform 3 squats, touching with his buttocks on the bed, and then just evaluate for pain, yes or no. Then we do the same thing with a single leg squat. Here we go a little bit higher because, again, with a single leg squat, we wouldn't go so deep, so it's about mid-thigh. And we make sure that the bed is sort of at the height of the middle of his thigh, and then perform again 3 squats. Is there any pain, yes or no? Okay, great. Then we let the athlete lie prone on his stomach. And we start with the palpation. So with the palpation, many of you will probably say, okay, palpation, what's the big deal? But to be honest, we found it quite amazing how different people can do the palpation. So we said, let's standardize it, and we start bilaterally and from distal to proximal. And why do we do that? Again, if the player has DOMS, if he has general muscle ache, it is important that we don't say, oh yeah, this is painful, but then you touch the other side, it's exactly the same pain. It gives you no valuable data on where the patient really is. So we palpate from distal to proximal, and then the player says, okay, yeah, that's my pain, that's where I feel it, the other side is fine, I feel nothing. We mark it with a pen, so we try to, first onset of pain, we palpate slightly up, then he says, it's still a little bit painful, come a little bit higher, and then the pain slowly disappears. We mark again, and we measure the length, and we note it in our next day assessment as well. See, does the pain decrease, does it increase? Then we come to the strength measures. So if you can come a little bit up. Here, to standardize again, we said that we dorsiflex both feet. Then the height should be about calcaneus height. So make sure that the toe matches up about with the calcaneus. Then we use the handheld dynamometer. Saying this is an eccentric test. In acute muscle injuries, we obviously do not want to perform this test if the player has pain. So here, we always say, don't push over your comfort zone. And this also gives you a lot of information when the player pushes and we compare left to right. Is he ready? How far does he really want to go? It's not just a number that we get, it's also the feel of the player. Then we give a command of 3 times push, 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 break the resistance, and we get a strength measure. We take the best out of 3. Then we turn the player around on his back. And we go to the outer range strength. Saying again, why did we choose about 30 degrees? As you all know, hamstring injuries usually occur in the late swing phase, so that's one of the thoughts we had behind that we obviously want to look more at the range also where these injuries occur. So we fixate the pelvis on the bed just to give a bit more resistance, and in your handball players, you've got guys that can push 50, 60 kilos easily, so this can be quite challenging to resist them. What we do here is 90-90, so about 90-degree hip flexion, 90-degree in the knee, and then we place the dynamometer again on the posterior aspect of the calcaneus, and we ask the player to push down, push, 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 and break the resistance. Read that off again. If you have fairly strong players, make sure to have the dynamometer somewhere on your iliac crest so you can sort of lock it in. Otherwise, it can be very ugly. I mean, if somebody pushes with 60 kilos down on you, that's not much fun. Again, here we're looking at pain response and strength. Then we go to the range of motion measures. So we've got a straight leg raise and the Aspetar test for hamstring length. So on the straight leg raise is a passive test. And what we said is we go to about, with our goniometer, we place the goniometer about mid-shin. So we measure that out, place the goniometer here, and then try to keep the knee in extension so we don't get any wrong measurements. I usually put my foot on here so I don't get any compensatory movement, and then read that off. Again, when the player says it's painful, we stop right there. If we can't go any further, it's basically till he says, okay, it's stretch response, I don't want to go any further. Compare left to right again. The next one is the Aspetar test. So what we do here is, and this really tests the outer range of the hamstrings quite well, we tell the patient to fix his thigh onto his chest by locking it into his elbows. Then we push this leg down, and nickel being very flexible, as you can see. This is an active test. So again, place your clinometer on the shin, and then the patient comes up, and we take the measurement and compare it left to right again. Here again, pain response, very important. The last test that we do is the bridging exercise. And here we are looking, first of all, can he actually get into position? So we asked the patient, can you lift your medial malleolus about the height of your medial joint space of the contralateral side? He can in this case. If you have bigger injuries, they might not be able to do so. Then we asked the patient, okay, can you do a partial lift off? Yeah, he's able to do that as well. Then perform a bridge 3 times. Is there any pain, yes or no? Then we do the same where the uninjured leg goes into full extension, hovers over the bed, and then we start again 3 repetitions. Is there any pain, yes or no? And then to make it even a little bit harder, so this would be in the later stages, we do the same with the leg on the therapist's shoulder, and the patient pushes up 3 times, yes or no. Okay. So you see, it's a fairly easy testing procedure. This took me maybe now, what, 6 minutes, and it gives me a hell of a lot of information about the player. So let's go back to our player that we saw before, and that nickel. Where are we going? So here's again our 20-year-old professional. Now he's 11 days after the injury. He's in stage 2 of his rehabilitation process, and he started some lengthening exercises and is about 50% of his running speed. This is what we measured. So the average pain was 0. He was pain-free doing walking. He had pain-free squat. As you can see, the strength is quite significantly lower than the uninjured side. So that would worry me already and would say, okay, I have to be careful to push this guy. Palpation length was about 3 centimeters, and he had pain-free ROM. Then we started doing some exercises. So here is Nickel performing one of the eccentric lengthening exercises, and this is the diver as prescribed by Askling as well in his protocol. And this is just one of the exercises that we did. Loaded him up a little bit, increased the running speed, increased the weights. And this is what we saw the next day. So the trunk flexion was painful. The palpable length of pain was about 20 centimeters, but it was more like general post-exercise soreness, and it was left and right. But now if you look at the strength dropped significantly. There was no pain, but the strength really came down. So therefore, the red flags should come up, and we won't push this guy today. The range of motion, straight leg raise, and the Aspetar test were 30% down, and they were painful. Saying that again, it wasn't the pain on the injury side, it was more generalized pain. The bridge was also painful, therefore the decision is quite clear, I think. I mean, once you have this starter, you just say, okay, this guy has to rest today. We need to give him some soft tissue treatment, do some ice treatment, reassess him again, and maybe take him back in our rehabilitation protocol so we cannot progress him to the next stage. So the take-home message is, it's difficult to predict return to play. Even with the clinical examination that Nickel has shown is quite good and better than other investigations that are on the market. But 5 days in a professional settings is still too much. I mean, if you're in a final, it's impossible to tell somebody, okay, it's 5 days more, 5 days less. You just can't do that. But that's as good as we can. Get structured daily monitoring. So the reassessment is the key. And a progressive criteria-based program, I think, is also very important to give a clear message to coaches and to the athletes. Thank you very much.
Thank you very much, Philip and Nicole. Any questions about this from the audience? Just over here. Have we got a... Yep, Jose? I don't know, is there a microphone anywhere?
Sorry.
Over here.
Yeah, first of all, thank you very much, Philip and Nicole, my great colleagues, for the great presentation. And my question is, during all your assessment, you are so careful and conscious of the pain. And my question is, why you stop when you have a pain, all those tests, if you're doing a braking test, maximal resistance, braking test, you know, so it can be very aggravating factor and it can change all your next test of stretching because it can aggravate the pain in certain stage of the injury.
So I know what you mean, because it is a maximum contraction and we're asking a lot from the patient, but to be honest, in these 100 patients that we've seen, in these 100 patients that we've seen, we've never had anybody that regressed because of the test. And I was very skeptical in the beginning as well, like when you do this eccentric braking, can we damage the tissue again? But the body is quite clever in that sense. I mean, you wouldn't push any harder than you can. And like I said, it gives you a lot of information about the patient as well. You know, if somebody says, no, I feel great, but he pushes only with 10 kilos, then sure, you know, it can't be that great, where you might have somebody exactly the opposite. So I don't know if that answers your question, but we haven't had any problems with doing a maximum eccentric test if it was appropriate, because in the beginning you would only do an isometric test if there's pain. Yeah?
Gentleman over there. And the
Yeah, thank you very much. It's very interesting. Obviously, we know with hamstring injuries there is a fairly high reoccurrence rate. And in terms of the rehabilitation program, is there anything that you would perhaps look at more specifically or highlight more in the program with a reoccurrer as opposed to with a first onset?
Phil?
Yeah, that's a good question. I think I didn't show it here. With our data, at least, what we've seen is this: if you're weak, your risk for an injury first time is higher, and if you're strong, your risk for a second injury is higher. So we've had a low recurrence rate in this data, in this group. But it seemed like the guys who tested really strong, especially in the quadriceps in their isokinetic test, had a recurrence soon after their return to sport. So the only thing we've done is we've taken it a little bit easier with the strong guys. But I think in terms of recurrence, we would follow the same program. And because it's criteria based, it's easy then, if someone gets stuck somewhere, I say stuck, but if they take a little bit longer, that's okay for us. We're not basing this on time, so we just wait until they're ready to progress to the next stage.
Any other questions? Perhaps I can ask a question to Philip. I know that most of your research involved footballers, and as we've heard from Cristiano, the epidemiology is quite different between football and handball. Perhaps the mechanism of injury is different. In your experience, do you need to rehabilitate footballers and handballers differently, or do you use the same protocol?
I don't know if this works. I don't think so. I think in the initial phase they're all the same. I think in the sport-specific rehabilitation, which in my opinion is the most important part, and that's where we are lacking in physiotherapy, thank God, not in Aspetar, because we have the facilities. It has to vary. Obviously, if I have a handball player, he has to do different sport-specific rehabilitation than a footballer and a sprinter and a high jumper. So that's where the big difference lies. But I think the muscle as such heals pretty much the same, and therefore I think there's not a big difference.
And just to add something to that comment, in our equation, if you played football, it made you take longer. So if anything, playing handball should get you back quicker, we would think.
Okay, sorry for Philip. I want to ask him for the rehabilitation program. If the lengthening exercise, you can start it in early stage, or it is dependent of the pain or the muscle healing. Also about the Nordic exercise, if you can start it in the rehabilitation program, or it is a prevention program.
So about the strengthening, if I understand right, because this was like 3 questions. The strengthening exercises, we have 2 protocols. So now what Unlog is doing at the moment, we're looking at early lengthening, that is from the beginning, so from stage 1, and we don't know, to be honest. We don't know if you can start with early eccentric load in the later stage, or should we do it in the early stage? So that's what we're doing at the moment. We're looking at that, and we will see if there's any difference in re-injury, in their outcomes. Can they come back early to play or not? So we don't know. We don't know. So that needs definitely more to be looked into. So far, what we've seen, and I don't know how many patients have been involved, but it's probably more Unlock who can answer you this question. We haven't seen any problems with introducing early lengthening exercises, eccentric load, and the injury prevention. Obviously, that's what we would hope for, and that when everybody goes back to the club with the Nordic hamstring exercises, that everybody would continue with that, and the results have shown to work. So it's the compliance issue. That's the main thing.
I think we have time for one more question, if there is one. Okay, so I think what we've learned from this session and previous sessions is that we need more research in handball injuries, and that we probably need more research in muscle injuries. But the challenge is really to be able to take this information that we get from the research and put it into clinical practice. And I want to thank all the speakers for their contribution. Hopefully this session has helped you in the way that you treat your patients. Thank you very much.